Welcome to Editor's Choice, the podcast of Neurointervention, where we highlight the latest science and research in interventional cardiology. I'm your host, Aaysha Cader, and through conversations with the authors, we explore study design, key findings, and their relevance in contemporary practice. I'm very pleased to be joined today by Dr. Shin Nagai and Professor Toyoaki Murohara from the Nagai University Graduate School of Medicine in Japan. And we will be discussing their paper published in Neurointervention titled Door to Unload Time and Mortality in Patients with ST Segment Elevation Myocardial Infarction Complicated by Cardiogenic Shock. Welcome, Dr. Nagai and Professor Murohara.
Thank you very much for having us today. Dr. Cader, we're very grateful for this opportunity and looking forward to discussing our study with you. Before we dive in, I would also like to thank all of my co-authors, especially Dr. Toru Kondo, my mentor and the corresponding author, Professor Masato Mutsuga, and Professor Toyoaki Murohara, who is joining us today, for their tremendous guidance and support.
Thank you, Dr. Nagai. So we know that about 10% of STEMI patients develop cardiogenic shock, and STEMI with shock carries a very high mortality to the tune of almost 50%. Tell us more about the background to your study and how this fits in with the pivotal danger shock and also the STEMI door to unload trials.
Okay. So STEMI segment elevation myocardial infarction complicated by cardiogenic shock, or STEMI-CS, remains one of the highest risk scenarios in acute cardiovascular care. Although door-to-balloon time has improved over time, mortality in STEMI-CS remains very high, so we need strategies beyond rapid PCI after hospital arrival. Recently, the danger shock trial showed that adding Impella CP to standard care can improve survival in selected patients with STEMI-CS. I think there are two important aspects of this device. First, Impella CP provides active mechanical circulatory support with flow up to 3.7 liters per minute. Second, it unloads the left ventricle by directly pumping blood from the left ventricle into the aorta. The STEMI-D2 pivotal trial addressed the unloading concept in a different population, patients with anterior STEMI without cardiogenic shock. It tested unloading before reperfusion with an intentional delay to PCI, although it did not show a significant reduction in infarct size. Our study fits between these two ideas. In real-world patients with STEMI-CS who received Impella CP, we asked the practical system questions. After hospital arrival, is earlier unloading associated with better outcomes?
Thank you for setting the stage as such. Now, let's talk a bit about the methodology. This study used data from the Japan Registry of Percutaneous Ventricular Assist Devices. Tell us about how you defined your study population from this registry, and also which patients did you exclude for the study and why?
Thank you. This is a very important point because Impella devices can be used in several different clinical scenarios. So we applied a strict criteria to create a clinically coherent population of patients with STEMI-CS. First, the J-PVAD is a nationwide multi-center observational registry that includes consecutive patients treated with Impella devices in Japan from over 200 participating centers. In Japan, Impella devices have been approved for the management of acute heart failure refractory to pharmacological therapy. For this study, we analyzed patients entered between February 2020 and December 2023 and focused on those with STEMI-CS who received Impella CP support. So the exclusion criteria was, first from the J-PVAD, we excluded non-STEMI cases and patients whose indications for Impella was not shock or low output syndrome. For example, we excluded cases in which the device was used only for escalation, procedural bailout, anticipated procedural support, or other non-shock reasons. This was very important because we wanted to focus specifically on acute STEMI-CS. Second, we restricted the study population to patients treated with femoral Impella CP. We excluded other Impella devices to reduce device heterogeneity, and we excluded non-femoral approaches because surgical implantation could substantially affect the timing of support. Finally, we excluded patients in whom STEMI occurred after admission or onset was not recorded, patients with missing door to unload time, patients who received Impella more than 24 hours after arrival, and those with unknown survival status. Overall, these criteria were intended to capture acute real-world STEMI-CS patients in whom door-to-unload time was clinically meaningful.
The primary endpoint was all-cause in-hospital mortality, And to evaluate associations between DTU time and in-hospital mortality, you stratified patients into 4 groups. Could you please elaborate further on this?
Yes, because the relationship between door to unload time and mortality may not be linear, we evaluated in several complementary ways. The 4 groups were practical categories that approximated the observed quartiles in our study population within 60 minutes, 61 to 90 minutes, 91 to 150 minutes, and over 150 minutes. This allowed us to evaluate the overall trend in a clinically interpretable way. We also performed 2 additional analyses. One used the 90-minute cutoff because 90 minutes is already familiar in STEMI care through door-to-balloon time. The other was looking at door-to-unload time as a continuous variable, including spline analysis, to assess the overall shape of the association.
Please tell us the main results of this study, starting with the patient characteristics and baseline parameters.
Of course, in total, we analyzed 1,783 patients with STEMI-CS who received microaxial flow pump support. The median age was 70 years, 17% were female, and the median door-to-unload time was 99 minutes. Regarding prior support, most patients had no prior MCS. Specifically, 1,294 patients had no prior support, 379 had prior VA ECMO only, 81 had prior IABP only, and 29 had both VA ECMO and IABP before MAFP placement. When we looked across the door to unload time groups, patients with longer times tended to be older and more severely ill. They had more in hospital cardiac arrest, more advanced sky stages, higher lactate and creatinine levels, and more frequent prior IABP or VA ECMO use. These trends were broadly similar in patients without prior MCS. In patients with prior VA ECMO only, the pattern was somewhat different, with patients having more out of hospital cardiac arrest, lower left ventricular ejection fraction, and higher lactate levels.
The main aim of this study was to investigate the association of DTU times and in-hospital mortality. So tell us what you found in terms of this association across the 4 DTU time subgroups that you previously defined.
Yes, overall, we observed a stepwise increase in hospital mortality as door to unload time became longer. In the overall population, in hospital mortality increased across the 4 door to unload time groups: 32.9% within 60 minutes, 33% between 61 and 90 minutes, 40.1% between 91 and 150 minutes, and 48.3% after 150 minutes. After adjustment, the 61 to 90 minute group was not clearly different from the within 60-minute group. However, mortality was higher in the 91 to 150-minute group and in the over 150-minute group, with adjusted odds ratio of 1.40 and 1.87 in Model 2.
And what were the associations with in-hospital mortality among those without prior MCS and those with VA ECMO only?
Yes, this was an important part of the analysis because prior MCS could strongly influence both timing and outcomes. Among patients without prior MCS, we saw a broadly similar pattern to the overall population. In-hospital mortality was 31.0% within 60 minutes, 28.8% between 61 and 90 minutes, 33.9% between 91 and 150 minutes, and 40.6% after 150 minutes. In the case of logistic regression analysis, the direction was consistent, although the individual categories were not all statistically significant, probably because the sample size was smaller in the overall population. We also looked at patients with prior VA ECMO only. Their absolute mortality was much higher overall, reflecting a sicker population. Again, the estimates were less precise, but mortality tended to be higher with longer door to unload times, especially beyond 90 minutes.
You also undertook subgroup analyses. What were the associations between an earlier door to unload time and in-hospital mortality across these subgroups?
Overall, the direction of the association was broadly consistent across subgroups, including age, sex, cardiac arrest status, lactate level, prior VA ECMO use, PCI timing, and the center's annual MFP volume. One exception was that the association appeared less pronounced in patients with a mean blood pressure of 70 mm mercury or lower. We also observed similar directional patterns in the analysis stratified by prior MCS status, including patients without prior MCS and those with prior VA ECMO only, although the estimates were less precise in these smaller groups. While overall, the subgroup's findings supported the main result.
An important aspect of microaxial flow pump studies is the occurrence of adverse events after device placement. So, what did you find, especially in relation to the groups you divided by the dose to unload timing?
Adverse events did not suggest a simple increase in major complications with earlier unloading. Bleeding requiring transfusion and stroke were similar across door to unload groups. Hemolysis were more frequent in the earliest groups, whereas peripheral limb ischemia was less frequent with earlier placement. The total support time for the initial microaxial flow pump increased with longer door to unload time, while left ventricular ejection fraction at device removal and NYHA class 3 or 4 status at discharge were broadly similar across groups. Well, this analysis was descriptive, so we should be careful not to overinterpret the mechanism, but one possible explanation is that patients with earlier MAFP placement were less likely to have prior VA ECMO. In those patients, the MAFP may have been used as the main source of mechanical support, which could partly explain the higher frequency of hemolysis. On the other hand, peripheral limb ischemia was more frequent with delayed placement, and this may partly reflect the higher use of prior VA ECMO and the more severe clinical profile in patients with longer door to unload time. But again, this is only a possible explanation, and our study was not designed to determine the exact mechanism.
You raise a very important point about the limitations of this study being that it is indeed observational, despite the fact that it does bring out some interesting insights. You did multivariate linear regression analyses as well, identifying factors associated with door to unload time. What did you find in this case?
The multivariable linear regression, longer door to unload time was associated with older age, lower annual institutional MFP volume, higher heart rate, higher creatinine level, prior IABP use, prior VA ECMO use, and PCI before MAFP placement. Among these, PCI before pump placement showed the strongest association with delayed unloading, followed by prior VA ECMO use. We think that this suggests that both patient complexity and system level pathways contribute to treatment delay.
And you also reported results of an interesting metric, the unload to first device time. What were the associations of this metric with in hospital mortality?
As I think this was very interesting. For unload to first device time, we performed this analysis among patients who underwent PCI after MHP placement. The main finding was that mortality was lowest when PCI was performed soon after pump placement. Mortality gradually increased as interval became longer and then reached plateau around 30 minutes. I think it's intuitive that early intervention is more clinically meaningful to these patients, but I think this is critically important because it suggests that earlier unloading should not mean delaying reperfusion. Once the pump is placed, we should move quickly to PCI. So the message is not unload and wait, but rather unload early and revascularize promptly.
So, taken together, what would you say is your main takeaway pertaining to door to unload time based on the findings overall of your study?
Okay, the main takeaway is that door to unload time appears to be a clinically meaningful, potentially actionable process metric in STEMI-CS. In this nationwide observational cohort, earlier MAFP initiation, particularly within 90 minutes of hospital arrival, was associated with lower in hospital mortality. We cannot infer causality from this design, but the findings support prospective evaluation of care pathways that shorten time to unloading, especially through earlier recognition, faster team activation, and coordinated referral to experienced centers.
I think you raised an important point about microaxial flow pump practice and training. You showed that high volume centers were more likely to initiate the device earlier. Would you say that this perhaps also supports the establishment of a hub and spoke model of specialized shock centers for such patients, Dr. Nagai?
Yes, I think our findings support the concept of organized shock systems of care, including hub and spoke models. In our analysis, lower institutional MFP volume was associated with longer door-to-unload time. This suggests that experience, team activation, and institutional pathways may influence how quickly an advanced support can be initiated. Of course, this does not mean that every patient should bypass the nearest hospital. If a patient is already at a PCI-capable center without Impella, reperfusion should not be delayed simply to shorten door-to-unload time. But if the patient is still in transit or if advanced support is clearly needed, I think early referral to direct transport to an experienced shock center may be reasonable.
This study shed some light on the timing of MCS relating to outcomes in STEMI setting, albeit, as you correctly mentioned, it being prone to some bias given the limitations of its observational nature. But the thing is, earlier microaxial flow pump implantation may prolong door-to-balloon times, which is essentially the gold standard metric for primary PCI. So in your study, you also reported that patients who underwent PCI early after microaxial flow pump placement had better outcomes. So in shocked patients, how would you reconcile this? What conclusions would you draw from this study in terms of the timing of microaxial flow pump placement?
I think, as you mentioned, it is very important that our study was observational and it's hypothesis generating. We cannot clearly answer if implant placement is better before PCI or after PCI. My interpretation is that we should not think of door-to-balloon time and door-to-unload time as competing metrics. In selected STEMI-CS patients, the goal should be early unloading and prompt reperfusion. If MAFP support is indicated and available, it should be initiated early, but once the pump is placed, PCI should proceed without unnecessary delay.
Thank you, Dr. Nagai. Professor Murohara, do you have any comments to add?
Yes, thank you very much. In our country, Japan, the doctors are mandatory to register the results of the implanting Impella after the introduction of this device 2020 in our country. So our data is consecutive patients, so it's a very accurate data. So I think our current data is very important for future, metric of quality of the high volume center of the treating a patient with STEMI with a cardiogenic shock. So we believe that our data is very important for this message to these hospitals. Thank you.
Thank you very much, Dr. Nagai, Professor Murohara, for discussing your very interesting paper and taking this deep dive.
Thank you very much.
Okay, thank you very much.
Thank you for listening to Editor's Choice. To read the full article discussed in this episode, visit eurointervention.org. And if you've enjoyed this podcast, please subscribe to Editor's Choice for more conversations behind the science published in Eurointervention.